So welcome again to Joint Inflammation and Pain, Finding the Cause. We are thrilled to have Becca Heckathorne and Nancy Durbin with us as presenters this evening to talk to you about joint inflammation and pain. I'll be introducing them in a little more detail in just a few minutes. As many of you know, at HFA, we really like to start with the patient voice because patients are at the center of everything we do. So before we get going with the presentation, we get to introduce Sherry Lucky to you, and she's going to share a bit about her story. Thank you, Sherry, so much for being willing to record a video for us and share with us.
Hi, I'm Sherry Lucky, and I have mild hemophilia B with a 10% factor IX level. I've experienced a lot of joint pain over the years. I have pain in both ankles, both knees, both hips, both elbows, both wrists, my right shoulder, and my neck. Sometimes I have relief and it's just one or two joints that are bothering me at any given time, but have had joint pain on and off for the last 15 to 20 years. I've tried physical therapy and I've gotten temporary fixes from physical therapy. And I've always wondered if I was having some mild small bleeding going on and if that could be causing my joint pain. So last year when I went to visit my hematologist, I brought it up and suggested maybe I need to try some prophylactic treatment. Maybe that would help. So she examined me and decided to do an image of my worst two joints at the time. So those were my ankles. I'd been doing a lot of gardening and both of my ankles were really bothering me. So she did CAT scans and she found that while some things were going on in my ankles, she didn't see anything that was the result of bleeding. So she recommended that I go to see physical and rehabilitative medicine. And so I saw them and they recognized immediately that I am hypermobile, and I had been told that multiple times over the years by doctors, physical therapists, occupational therapists, my TMJ doctor. So I knew that I was hypermobile, and they, PM&R thought that that could be causing the joint pain. So they recommended that I go to occupational therapy and physical therapy. So when I went into occupational therapy, I went in with the request that when I was done with therapy, that I left with a reasonable program that I could do at home weekly, and then tools in my bag of tricks for when I have flare-ups to help with that. So I did occupational therapy for 3 months. We decided to stretch things out rather than doing 3 visits a week because I had a limited number of visits. So we stretched my visits out from 2 in the beginning and then 1 visit a week to once every other week. And then a final follow-up. And I did make progress. I made progress and I left with exercises that I could put into my regular routine every week and tools in my tool bag for when I have flare-ups. So I have a splint that I can use when I need to, which I use as little as possible because I want to maintain strength. And then I also have learned how to do some taping to support when I need the support, and then some taping to just take stress off of certain muscles or tendons that need that relief sometimes. And so it was exciting to find out that I didn't need to start a prophylactic factor replacement, and that I can, through exercise and strengthening and learning more about how I hold my body and how my body has adapted in 50 plus years of having loose joints and my body compensating and holding postures in different ways to protect my joints. Just the more knowledge of that and working on that, the continued work, I think, is also really going to make a difference. So thank you for letting me share my story about how my joint pain was in fact not caused by bleeding into my joints, but by weaker joints because of them being lax and being hypermobile. Thank you.
So thank you to Sherry for sharing your story. And at this point, I want to introduce you to our two speakers, Nancy Durbin and Becca Heckathorne. We are thrilled that they're both here with us this evening. Nancy is a physical therapist currently working full-time in the Hemophilia Center at OHSU in Portland, Oregon. She has over 15 years of experience working with both children and adults at the HTC and 20 years of experience working with children with chronic pain at the Pediatric Pain Management Center. When not at work, she is playing in the wilderness, hiking and canoeing, or sitting on her back porch enjoying the Pacific Northwest's rain and sunshine. Becca Heckathorne is the lead nurse at the Hemophilia Center at Oregon Health and Science University in Portland, Oregon. She has worked in the bleeding disorder community for 5 years, and prior to that, spent 10 years working primarily in pediatric hematology oncology. She lives in Portland with her fiance and their pets, Winnie and Lily. When she is not at work, she enjoys spending time outdoors in the beautiful Pacific Northwest and hosting dinner parties for friends. Before we get started, I want to remind you that we do have a Q&A option that you'll find at the bottom of your screen. Please send in your questions as they come up. Even though we're going to hold the Q&A session until the end, please feed us the questions as you have them, because we're going to be organizing them behind the scenes and grouping them to make sure that we can answer as many of your questions as possible at the end of the presentation. And with that, we are going to advance the slides. I just have a couple of thank yous. So thank you to all of our sponsors who partner with HFA to allow us to present these webinars and bring critical information to our community. And then we'll turn it over to Nancy and Becca. Thank you both so much.
Yeah, thanks for having us. Tonight we are going to start off with some definitions. It might be a little bit dry to start, but I think we figured it was important to kind of have a framework for what we're talking about. So the first definition I want to talk about is inflammation. This is about joint inflammation and pain. So what is inflammation? According to Tabor's Medical Dictionary, inflammation is an immunological defense against injury, infection, or allergy, marked by increases in regional blood flow, immigration of white blood cells, and release of chemical toxins. Inflammation is one way the body uses to protect itself from invasion by foreign organisms and to repair wound tissues to wound tissues. The clinical hallmarks of inflammation are redness, heat, swelling, pain, and loss of function of a body part. Systemically, inflammation can produce fevers, joint and muscle pains, organ dysfunction, and malaise. And then moving on to the next definition, I want to talk a little bit about pain. But before I talk about pain, I do want to mention that I think it's important to note that the signs and symptoms of inflammation are very similar to the signs and symptoms for bleeding. So it's understandable that there could be some confusion as to, is this a bleed, is this inflammation? So moving on to pain. Pain is an unpleasant sensory and emotional experience arising from actual or potential tissue damage, or described in terms of such damage. Pain includes the perception of an uncomfortable stimulus and the response to that perception. And this definition is from the International Association for the Study on Pain. We know, Nancy, if you could go forward to the next slide for me, we'll talk a little bit about different types of pain and inflammation. Both of these can be either acute or chronic. We'll talk a little bit about inflammation. Acute inflammation is when your body responds to sudden damage, such as cutting your finger, and then to heal your cut, your body sends in these inflammatory cells that we talked about, and these can start help the healing process. Chronic inflammation is when that stimulus is no longer there, but your body continues to send those signals, making you think that there's something going on. So you can see this in things like rheumatoid arthritis, where you can get kind of a flare-up, and then it can get better. So that's a little bit of definitions on acute versus chronic inflammation. The same goes for pain. You can have an acute pain issue or something that's more long-standing and chronic. If we can go to the next slide, I want to talk a little bit about what that looks like in the bleeding disorder community. So for Nancy, if we could go forward just a couple of slides.
So it appears that Nancy froze for a second.
Okay.
So we're going to see if she pops right back on. And if not, maybe one of us could share our.
I can share it as well.
Perfect. Becca, why don't you bring it up right now so we can continue?
Give me one moment. Just want to make sure I can still see my notes.
Thank you all. Gotta love technical issues for sure. Never a dull moment.
Almost there.
All right. Thank you, Becca. I appreciate it. And I am sure we will see Nancy pop back on.
I have it up as well, Becca, if you want me to pull it.
I am just about ready to share my screen, but thank you. Just make sure it's the one. Okay.
Thank you.
Can you guys see that? Let me advance to the right slide.
We can see it.
You can?
Yes.
Okay, great. Okay, acute versus chronic. We've got our cut finger, our chronic inflammation, and so causes. What are some of the causes of joint inflammation and pain in bleeding disorder community? So as most of you are probably aware, people with hemophilia, A and B, and von Willebrand's, there can be several causes for pain and inflammation, but obviously the big ones that we think about are bleeding. So we can have joint bleeds, microbleeds, soft tissue bleeds, and then there's this other category. Nancy is actually going to spend quite a bit more time on the other category than I am on the bleeds, since that's what we're here for. But I do want to touch on some of the things, like the signs and symptoms that we typically look for in bleeding to help us differentiate kind of what we're looking at. So joint and soft tissue bleeds. With both joint and soft tissue bleeds, I know this is more focused on joints, but I figured we'd talk a little bit about soft tissue bleeds as well, because they can also, you can also have inflammation in your soft tissues. And so I've kind of lumped them together for the purposes of this talk. So signs and symptoms that we see in both of these are pain, swelling, loss of range of motion, warmth when you touch the area, redness, and sometimes bruising. And again, for somebody who has a factor 8 deficiency, factor 9 deficiency, or von Willebrand's disease, the treatment is likely going to be factor replacement, and then what we call RICE, which is rest, ice, compression, and elevation. And then once we know that the bleeding has stopped, then we can start mobilizing and getting you back to back to your regular functioning. So I think the key differences here between joints and soft tissues is that with soft tissue bleed, you might not always see a loss of range of motion, whereas in a joint bleed, you typically do. Soft tissue bleeds can take a very long time to heal because the body has to reabsorb any blood that's gotten into the soft tissues, and that can take a really long time. For any bleeding episode, sometimes the only way to know whether you've had a bleed is to treat it as if you've had a bleed. And then if it resolves, we assume, okay, that was a bleed. We did the right thing, we treated it. If you treat it and there's no improvement though, then that cues us to think, okay, something else is probably going on and we need to figure out what that is. So sometimes, like Sherry mentioned, there can be medical imaging that can be done that can help determine if it looks like there's been bleeding into a joint space or not.
Becca, I'm sorry to interrupt. Do you mind slowing down just a hair so the interpreters can catch up a little bit?
Oh, sure. No problem.
You don't need to stop at all. Just a tiny amount slower and they'll be able to keep up. Thanks.
Sure. Okay, so next we're going to talk about microbleeds. I labeled this a hot topic just because, well, I'll get into that. First, I'm going to define it like I did inflammation and pain. So a microbleed is an asymptomatic leakage of small amounts of blood into the joint. So again, asymptomatic or subclinical, meaning there's no evidence that bleeding has happened. The reason I call this hot topic, even though it's maybe not a true hot topic, is that it's a little bit not well understood. So studies have been done looking at people's joints, people who have bleeding disorders and people who don't have bleeding disorders. And they've done imaging of joints that have no known bleeding episodes in them previously. And when they compare the joints in those two populations, they weren't able to find any significant changes between either group. So basically, if there is microbleeds happening, we aren't very good at identifying them, and we also don't really know the implications for what happens when people get microbleeds. So, you know, we believe that they happen, but we don't really quite know what to do about it yet. So I won't spend really any more time on this, except to say that we know that that's a thing, but the focus of this presentation is going to be a little bit more on the things besides bleeding that can cause joint pain and inflammation. And so that was perfect timing, Nancy. Welcome back.
Oh my God, that was a little heart attack.
So I've gone ahead and I have the presentation open. I'll forward the slides for you, and I'm going to hand it over to you so that you can start talking about causes of pain and inflammation that aren't related to bleeding.
So sorry, Becca, are you going to keep this up and I'll tell you when to flip? Okay, sounds great. All right. So my role, now that I can calm myself down, is to talk about the other causes. What do we do when it's not a bleed? What could it possibly be? Okay, next slide. All right, so there's a lot of other things that we look at, and I love Sherry's voice in this because she really talked about hypermobility. That is real, and it does happen for many of us when our joints are really flexible. But there's other things that can cause pain. So hypermobility, overuse syndromes is what we call tendonitis. Muscle imbalances, deconditioning, weakness, and hypomobility can all kind of go together to create an inflammatory, painful situation. Osteoarthritis, and this concept of peripheral and central sensitization. So I'm going to go through all of these in the next few slides and talk about how they can cause pain and inflammation. So next slide. So let's talk about hypermobility first, because that's what Sherry brought up. Not all hypermobility is a problem. Hypermobility basically is just that your joints are very flexible. Some people have a lot of flexible joints, and they're great at parties. They can show you how much they can twist their legs around or move their arms. Hypermobility can be one joint or it can be several joints, and even one joint can be painful. And PTs will look at if there's something that is moving too much. It might be because of some of that muscle imbalance that we were talking about in some of the causes. But hypermobility doesn't always need a geneticist. There's a lot of different variation in hypermobility. But the one thing that we have found with hypermobility is consistently that exercising and moving in a controlled manner is the one thing that will consistently improve pain. But when we look at exercising, we look at everything. We look at creating a healthy lifestyle. How can you sleep better, eat better, move better, support your joints with maybe some protective pads and supports? PTs and OTs are really helpful in structuring a strengthening pad program to help with this condition. Okay, next slide. So what do we do for hypermobility? Oh, sorry, one more back. We look at supporting the joints through strengthening muscles, and there's lots of ways to do that. We can use therapy or resistant bands, and we look at just amount of movement that will support your joint but not aggravate it. And supports can look at how do we support your movement overall. Sometimes it's with braces, and these are not supporting any particular brace in general, but we look at joints that may be more unstable or that dislocate, and how can we keep them in good alignment? And we can do that with braces on knees, simple supports at wrists, or maybe they need a little bit more support, and we would look at that. We really aim to get aerobic conditioning back in. So if walking is difficult, even something as simple as a walking stick could be something that gives you enough support to protect that joint and help exercise it more. Slide. Sorry, next slide. So if it's not hypermobility, what else could it be? Well, then this concept of overuse syndromes is what we call tendonitis. Tendonitis is when you've got irritation of a tendon. So a tendon is what connects a muscle to a bone and allows us to move. But that tendon can get irritated with very repetitive movements, and that can cause inflammation and can cause pain. So you'll hear things like carpal tunnel or tennis elbow or jumper's knee, Achilles tendon, de Quervain's tenosynovitis. All of these are different joints that have been overused and you get an inflammatory response. So it can happen at any joint, and we need to look at that joint to see what created that and what we can improve. So next slide. So who gets a tendonitis? Anyone can get a tendonitis, but unfortunately, as we get older and more mature, our tendons also age, and they're not able to tolerate as much stress. They're less elastic and they're more likely to tear. So things that you used to do when you were young, you're going to have a little bit more difficulty as we get older because you don't have the flexibility in those tendons to take that kind of activity. So things like gardening, landscaping, vacuuming can even do it. Certain job tasks like typing or repetitive lifting at work. There's sports that you may pick up, like pickleball is a new one. People will have never done it before, and suddenly they start doing a very repetitive movement and they can get injuries. And oftentimes as we get older, these activities tend to be done on a weekend or an evening when we have some time to do it. So we're cramming in a lot of repetitive activity in a short amount of time, and that can really aggravate the tendons. And the other things that involve tendonitis is looking at posture. Our posture and how we sit and how we stand can lead to tendonitis because we'll put stress on a tendon if it's not in a good position to work with in the first place. When you think about lying in bed and texting and using Instagram and TikTok, we have a lot more tendonitis and pain in necks and wrists and fingers because people are doing a lot of repetitive movement in these positions that don't line up your joints in a good way to use them well. Oh, I want to talk about one more thing. Sorry, I jumped ahead. So yeah, tendonitis management. So yep, there you go. How do you take care of this? It sounds simple, but you actually need to avoid the activity that's aggravating the tissue for a short amount of time. You need to rest it. That area has to heal. Icing is a really effective tool for decreasing inflammation in an area that's aggravated. Sometimes we use anti-inflammatories, and Becca's going to talk a little bit more about that at the end of what medications are available. And all those are very simple approaches to decreasing the inflammation, but sometimes we need a little bit more help. And if you do, we will refer you on to someone who, like an orthopedic, who can look at injections. Injections are something that's just a very specific anti-inflammatory to the area that's aggravated. And that can be really, really helpful to decrease the inflammation. But also PT and OT also have a huge role in this, because we look at bracing and we look at stretching. So People will get into patterns of moving, and sometimes having another person look at that and figure out what your patterns are, and stretching and bracing can be really helpful in allowing a joint or a tendon to rest so that you can it can start to heal. And ultimately, surgery sometimes is an option as well. Carpal tunnel is when you get enough inflammation that the tissue in that area gets really thickened. And the only way that's going to relieve the pressure on the nerves and in that joint is to do surgery. So sometimes that is a further progression of what you need to do to take care of an area. But the biggest thing to remember is it can take weeks or months to resolve. And I really appreciate Sherry's point in this, that she was in PT and OT for 3 months. It wasn't something that happened overnight, improved overnight. It takes time. It takes looking at your patterns, it takes looking at what you're doing, and it takes strengthening to improve that, to improve the tendonitis. And then ultimately, how do you avoid it into the first place? Sometimes it's hard. We only have a limited amount of time to do things, but truly stretching and warming up your tissues is really important before you perform an activity. So lots of times we just dive into, we've been sitting for 8 hours in our chair, and then suddenly we have to go move a bunch of mulch in our backyard. A couple of simple stretches will help get blood flow to that area, help relax it, and let us move through that activity. So stretching and warming up is really important. And again, starting slow. If you're going to pick a new activity, think about doing it in a sort of a slower manner. I come back to pickleball because that's the hot topic right now for people doing. If you're going to go out and play, don't play for 4 hours the first time you go back and then go the next day or the next weekend. Start slow and build that strength up. And think about the equipment that you're using as well. Are you have a racket that's too big or too heavy? Are you using the right chair for when you're sitting and doing typing? All these sort of supports that you can work into ways that protect that joint. So shoe wear and even clothes wear, wearing something that's looser and not tight can help prevent this from happening. And pacing is a big deal. Going slower, listening to your body, maybe taking breaks, can make a big difference in managing tendonitis. All right, so the next concept, we've talked about hypermobility and tendonitis, this concept of deconditioning. If we are been inactive, and COVID for sure has impacted on the activities that we've been able to do for a lot of years. Some of us are sitting for much longer periods of time than we ever have before. You can develop weakness, muscle imbalances, some things are stronger than others and they work against each other to not support a joint that ultimately can lead to hypomobility when you don't have a lot of movement in a joint. So all of these things can be connected. And what this diagram sort of shows is that injury is going to happen. All of us are going to bump our knee or twist our ankle or do something that we injure ourselves. And like Becca said, there's a normal, natural inflammatory response that brings needed chemicals, blood flow into an area. So if you get an injury, inflammation is something that should happen. You want that to happen. And pain is a really important piece of that because it makes you aware of that area and it's giving you the cue to not use it or let it rest. So typically when that happens, we move to the right of this diagram. We use price, which means you protect that area, you let it rest, you use ice, maybe you add some compression if that feels good. And that you elevate it. So those simple, they sound very simple, but they're very effective in allowing tissues to start to heal. Our body is amazing at its ability to heal itself if we set it up to do these things. So typically you get tissue healing in a pretty short amount of time. Then you move to strengthening because you can't just jump back into the sport or the activity that you're needing to do. Muscles get a little weak, you have to strengthen them, and then you get to your road to recovery. But sometimes we get to the left of this diagram. We have inflammation and pain. We get this initial protective response, but things like fear, worry, and stress, if we don't know what's going on, we worry, we kind of overprotect that joint. Pain to us becomes the symptom that we're really worried about. What should we do? And then we end up overprotecting and developing muscle weakness and atrophy. Atrophy basically meaning that you're losing muscle mass when you don't use it. So this concept of use it or lose it is really, really true to life. So if you're not using the muscle and it's getting weaker, then you wind up into this concept of you get chronic swelling because you've got a weak muscle that's aggravated with a little bit of movement. Our tissues get more rigid, they're more prone to injury. And then we wind up in this whole cycle on the left side and we just keep we have more worry, have more stress, and we wind up over here. The good news is you can flip it back over if we start to move a little bit. Oftentimes it's scary, but with a lot of education, with learning how to move our bodies, we can do safely to get back to the other side of this diagram to recovery. Okay, so I also wanted to talk about that inactivity, and why does inactivity lead to sort of this inflammatory piece? So our bodies really have two types of muscles, and we call them mobilizers and stabilizers. The mobilizers I like to also talk about as sort of the party animals. Those are the big muscles that get all the tension, the triceps and the biceps and the big muscle six-pack abs. These are the ones that move the body in big, big patterns. But the problem is when we are inactive or we rest for extended period of times, these muscles contract and they get shorter and they atrophy, meaning we lose muscle mass. The stabilizers are the deep muscles that I like to call the nerds. They're the ones that keep the music on and the lights going. They are there for you anytime. But the problem is when we are inactive, they get weak really fast. These are your muscles like your rotator cuff in your shoulder, the deep muscles of the hip and the deep muscles of the abdominal muscles. So this diagram really sort of explains how mobilizers and stabilizers work together. So if you look to the right of this, picture this as your spine. It doesn't have to be your spine. It can really be any joint in your body. Your stabilizers are those deep muscles that keep your joint lined up. So now when you go to move your big muscles like your triceps or your extensor muscles in your back, those joints stay really well aligned. So they work together. Your stabilizers keep the joint in a good position. Your mobilizers move it through space. On the left side of that diagram, if you've been inactive and you have weak abdominal muscles, you're not able to support that spine in the way it should be supported to move. So now when those big mobilizers go to move, they put undue stresses on those joints. You're going to aggravate nerve endings. You don't have the stability that you need to move. So again, those muscles can get shorter, they get overactive, and they're really pulling on the joint, and that can cause a lot of pain and inflammation. So we talk a lot about posture when we're looking at mobilizers and stabilizers, and they always work together. So this is a great diagram. It's not so much that you need to know all the different muscles in the body as much as that you know that if one muscle is weak, there's an opposing muscle that's probably tight and overactive. So if we look at the neck, you've got a lot of wonderful, deep stability muscles in your neck that hold your chin in place and keep you well aligned. If those muscles get weak, you start to get this forward head position. And when in that position, a lot of muscles in the back of the neck get really tight and are overactive. This can cause pain in the neck. It can cause headaches because there's an imbalance between the mobilizers and the stabilizers. Moving down the body, you've got the shoulders. If you're sitting in front of a computer and your shoulders are constantly forward and you're looking down, the muscles in the front of your body get really tight. Those are the mobilizers, and the ones in the back that support your shoulder and your posture get really weak. And this happens all the way down our bodies. If we look at our hips, our abdominal muscles, our deep ones get weak. We overuse the back muscles and they pull on the spine and they can cause inflammation and aggravation. So PTs do a really nice job of looking at what's weak, what's tight, how can we work these together so they're helping to keep our joints aligned and allow them to have the least amount of inflammation and pain. Next slide. All right, and osteoarthritis is a real reality in bleeding disorders. We know when we have blood in a joint that when that blood gets reabsorbed, it actually has byproducts that aggravate the cartilage and aggravate the bone. We also know that you can have osteoarthritis and not be bleeding. There's a low level of inflammation that comes with just having less cartilage and bony irritation in there. And often that low-grade inflammation is aggravated by things like poor sleep and inactivity, because pain makes you not want to move. And when you don't move, you get more muscle stiffness. So all these things outside the triangle are things that contribute to that low-grade inflammation that's happening in osteoarthritis. And so what I love about this one article, it really talks about the first line of intervention to help this low-grade inflammation that's going on with osteoarthritis is to look at our nutrition and look at our physical activity, because those things in combination can really help decrease the inflammation that's going on with osteoarthritis. So how do we manage all this? Those are the things that can cause pain and inflammation: hypermobility, hypomobility, muscle imbalances. All those things can be a factor in having joints that are painful and inflamed. So what do we do about all this? And I would say the first thing that we do is we start with a really good pain history. Because typically it's not that one thing you did today that caused your joint pain. It's the 15 things that led up to it. I didn't have good sleep. My kids are driving me nuts. Work is very stressful. All these things can contribute to what's going on with you in that moment. So we do a lot of question asking and finding out, what did you do in this moment? But what have you been doing for the last week that may be contributing to this pain? So we think through all those events, and then we often ask what makes it better or what makes it worse. It's very rare that nothing makes it better. And if everything hurts all the time in every position, then we start looking at your sensitization, that things are really amped up and hyped up, and that can be a problem too. So oftentimes we look at, is a little bit of a position change make it better? Does rest make it better? Does ice make it better? It can really help us sort of narrow down what's going on in the joint when we ask the questions of what makes it better or worse. And again, that leads into, how are you sleeping, you eating, you working, you're playing and resting. All of those things are key in figuring out what's going on with your whole system. What's too little, what's too much, and what's just right. So sight and direction is really important. PTs will often look at this, because if we look at what joint hurts and what directions hurt when you move it, it can give us a lot of information about whether it is a joint bleed or whether a muscle is aggravated, whether it's tendonitis or where there's some strength imbalances. And a big piece of it is, has it spread or has it remained local? And that has a lot to do with persistent pain. And the reason why I put that tea kettle up is because persistent pain really changes the nervous system. So when I talked about central and peripheral sensitization, I often use the analogy of a teapot, this concept of, if there's a lot of things going in your life, it's almost as if there's a tea kettle that's consistently on simmer. So it doesn't take a lot of extra things to make that tea kettle boil over. And that's what we're looking at. If persistent pain will impact the nervous system, so that even little things will aggravate it to a high extent. So when we talk about pain management, we talk a lot about education. And what's really important is, what I loved about Sherry's her video was that she talked about what was important to her. She wanted to walk away with tools that she could use. Don't give me an exercise program in this moment. I want to know what I can do long term. So being able to vocalize what's important to you is a big part of pain management and pain education. But it's very much a two-way street. The science of pain has come a very long way. We know so much more about the complexity of pain. We know that our thoughts, our feelings, our behaviors, all of that directly impact our pain perceptions, for better or for worse. So the beautiful thing is, I often tell people, like, your brain will blow your mind. It's so much that goes on in that. The bioplasticity, meaning that you can retrain your brain and you can retrain your nervous system, you can retrain your muscles to improve. All right, I'm going to have you flip to the next one. And this is a really good, I love this to sort of say how, like, stress can sensitize the nervous system. So you generally have a fair amount of tolerance to pain. You can take a lot before things bother you. But if you have poor nutrition, you have you're going to be more susceptible to things that cause pain. So if you lose social support, if you feel isolated because you've been sick and you've had to stay home, now you've become deconditioned. You have stressors at work, your fear that you're not going to get better, you have poor sleep, you have weight gain, all these things add up to that tea kettle where you don't have a lot of space to be able to tackle anything that is going to potentially be too much for your body. All right, so what do we do? In terms of PT, we always emphasize motion. Motion is lotion. When you start to move a joint, you're bringing blood flow to that area. You're bringing nutrients in and wastes out. So motion can really help loosen up ligaments. It can help strengthen muscles. There's so much that motion is good. So generally, we emphasize this fact that when you move, your brain has actually its own pain medicine, and that can help you move more. So then the other piece is that we often talk about that hurt doesn't always mean harm. It may not feel good to move, but as you move more, you're not damaging tissue, you're actually helping it. And I did want to talk about, this is a wonderful sort of explanation of this concept of hurt versus harm. Mosley and Butler are two physical therapists out of Australia that do a lot of work on the science of pain. And this is basically set up to show that before an injury versus what happens to after injury. Before an injury, we are able to climb that mountain, we're able to do things. And that first red line is that when you're doing an activity, you will at a certain point feel your muscles. It's like, okay, I'm starting to feel something, but I'm not hurting any tissue. There is a buffer of area that you're able to work in, that you're able to keep going, but you're not having tissue damage. That next line up is that when you cross over and you have tissue damage. So you sprain your ankle, or you've worked so long that your tissues are so irritated that they break down. So finding that sweet zone is where we all want to work in. After we've had an injury, that whole sweet zone actually lowers down. So this concept of I used to be able to do a lot of stuff, but I can't do now, that lowers down because of that deconditioning and inactivity. So we still have a zone where we can work, where we might feel our tissues, but we're still safe. We're not harming anything. But this is where we need to work and rethink things like how much work can I do without bumping me to the tissue damage? How much that I can feel it and know that I'm still safe. It may not feel great, but I'm still improving that muscle strength. And that's the zone that we're looking for. So often treatment for pain and inflammation is multimodal. We want to look at an aerobic. Walking is like the simplest, oldest exercise you can do. If you can't do anything else, that is a wonderful exercise to start building strength in our hips and our legs and our lungs and hearts. We look at KT tape, we look at orthotics, gentle movement, we look at ice or heat, what makes the most sense and what is needed at that time. Light weights are really good for building up bone density again. And then the one piece in this I want to emphasize for the next click is that we have to retrain how we move and how we think. So this is the neuromotor changes that we need to make, is like how we look at pain and how we learn about what our bodies can do safely. So lifestyle changes, and this is the piece just briefly that we all need to think about. Maybe we need to pace our activities, and sometimes it might be a matter that we purchase something like a Roomba if we don't want to do all the vacuuming around our house. Looking at job accommodations. Do we need a standing desk that lets us move up and twist and move a little bit more than sitting all day? Mouse pads, keyboard pads can change how we give our joint support. Maybe we need more rest breaks if we're doing a lot of gardening or sports activities, or maybe we need more movement breaks. If we're sitting for long periods of time when those mobilizers get tight, can we stand up and stretch them out? And identifying those triggers that make things work and recognizing that pain might be giving us some information that we need to take a break. Maybe we need to improve our sleep or what we're eating. So we need to be thoughtful about those triggers and what will set things off. So essentially to develop a toolbox of strategies. And I just want to emphasize here, self-compassion. I know I'm running through this, but self-compassion is really important. Give yourself the time to heal. We often think things have to happen in a minute. Time and being okay with sometimes having bad days or not such good days, and that's okay. That doesn't mean we've lost any gains. It just means give yourself that break for that day, and then tomorrow you can do a little bit more. And then I just wanted to emphasize that be curious. We get into patterns of thinking and patterns of movement that really impact our pain. So take a step back and explore it. Pain is information. What is it telling you and what can you change? That attention is pain management and is the first step in helping you heal. And now I think I'm going to flip it back to Becca for some info on pain medication.
Thank you, Nancy. I will just spend a very quick minute talking about safe medications for bleeding disorders. There is not a whole lot to say here because unfortunately there aren't a whole lot of anti-inflammatory medications that are safe for people with bleeding disorders to take. Most of the NSAIDs that are available on the market increase bleeding risk. And so there's really one that you have probably heard of that we use, and that's Celebrex, or I don't even know how to say the generic name. Let's stick with Celebrex. And it is the only one that doesn't increase the risk of bleeding disorders, but there are some side effects that it has. So it is something that you would want to make sure that you talk with your hematologist about and make sure that it's safe for you to take if you have any other health issues apart from your bleeding disorder. And then of course, the other medication that we use is Tylenol. Tylenol can be good for pain control. It doesn't help with inflammation so much, but maybe a combination of Celebrex and Tylenol and some of the things that Nancy talked about earlier, ice packs, cold water, things like that, that can be actually really helpful for more mild inflammation. So at that kind of wraps up our talk, and I think we're ready for some questions. I guess I can stop sharing my screen now.
Excellent. And we have tons of questions, so I'm really excited. I think I'll do my best to sort them and get them to us. We may ask if we can stay on just a few minutes over to answer, because we've got some really good questions coming in. So the first question I see is asking if you could speak about I believe it's the musculoskeletal ultrasound. And the question is, can it really show blood? Can it really show if someone's having a bleed? And if not, what diagnostics can?
I guess I'll take that one. So yeah, musculoskeletal ultrasound is really becoming a new tool in a lot of treatment centers. And it's been shown to be really helpful in identifying what's going on in the joint. So you can tell if there's a bleed, and you can tell if there's inflammation going on in the joint. They look a little different. And usually if you're with someone, they can explain that why. So often on an ultrasound that we do, it's really effective at telling that there's a new bleed in there. It's a matter of how the tissue moves that can help identify it. And again, I just feel like it is a tool combined with sort of the history of what has gone on to get you to that painful point that can give us a lot of information. So it's hard for me to say. It's easier for me if I had an ultrasound in front of me, and if I was looking at your joint, I would be able to tell you the characteristics of why it looks like blood or why it looks like soft tissue inflammation, what's going on the joint in terms of the cartilage and the bone, and all of that together helps us decipher that if it's a bleed or if it's not a bleed.
Thank you, Nancy. The next question, for my ankle arthritic pain, it sometimes presents upon weight bearing, but sometimes the pain is worse when I take my weight off the ankle. I haven't been able to determine any particular cause for one type over the other. In general, when I'm on my feet or standing for a prolonged period of time, the arthritis flares the next day. Any ideas of the causes for these distinct types of arthritic pain?
So I think when you've got a small amount of joint space, because arthritis means that you've lost the cushioning of the cartilage in that joint. And then when you lose that space, your muscles are tighter around that area. And part of that, I think, is when you take the weight off, you're finally letting go and you're relaxing a little bit. And that's when the inflammation may be more apparent when you're feeling it at that point in time. So it's so interesting because arthritis pain really has a fluctuation to it. When people sit for long periods of time, those muscles tighten up and they actually feel better initially when they start warming up that joint and moving. And then a lot more activity can actually aggravate it. So arthritis is never sort of like a one size sort of pain all day long. It really can fluctuate with the activity you're doing and with how much movement you're able to do. That makes sense.
Yeah, thank you, Nancy. And I just have to say, when I was listening to you present, the moment you mentioned posture, I sat up straighter, and I wonder how many other people were suddenly called into being very self-aware of their posture while listening, which is a good thing. We need to be aware. Next question. I have hemophilia A and hypermobility and have been diagnosed with tendinosis. Can you elaborate on the osis part versus the itis part?
So the osis is where you have a thickening of that tendon over time. So it's been irritated and it responds by getting thicker and stiffer. It gets irritated, so there's little micro tears, it gets thicker and stiffer. So a tendinosis means it's thicker and it's less resilient. So an itis is sort of maybe more of the acute stage, and the osis is what happens over time as that gets thicker and stiffer and less resilient.
Thank you. The next question: how can we deal with pain when factor or other bleeding disorder medications are not an option for the patient, and when the patient wants to avoid opioids?
So good for you. Opioids have a role in pain, but long-term use of them is really difficult on our bodies. And what we're finding is that I've known a lot of people who have actually weaned themselves off of opioids, and their pain may not change, but they're able to do more. And that's huge. So we look at function. So I credit you a lot for thinking like, I want other options other than opioids. I would highly suggest is talking with your care provider about asking that exact question, what other options are there for you. We are very fortunate here at our center to have an adult pain management center. And there are some medications that aren't opioids that could be very helpful for you. And I don't feel I can list all of those names, but I would say that I incredibly value the adult care providers at our pain center for working with people individually on what works best for them. And then holistically, it's really great to think of getting involved with your physical therapist or your occupational therapist and finding out what your goals are and what you want to be able to do and how can we build that strength. There's very simple like modalities like Becca talked about, ice or heat, and those things can help sort of in the moment, but it's how do you come up with an entire sort of toolkit that works for flares or works when you're having a good day or works when you're having an exceptionally bad day. There's lots of things that you want to have sort of a toolkit of supplies that I look at it as sort of like a menu, like what do I need today? I need a lot of dessert today, or I need a lot of my main meal, or give me some veggies. It's like your menu, you're not going to eat everything off of that menu, but some days you're going to pick and choose what works best for you. But go for it, Becca.
No, I didn't want to interrupt you. I just wanted to talk about the Oregon Pain Guidance website, which is another kind of multimodal tool that we've been introduced to in this last year that gives some really good guidance on, like what Nancy was saying, sort of the more holistic approach to care that might include some medication, but talks, focuses on all of these different ways that our brain perceives pain and how we can do things to help lessen that or alleviate it. So I don't know if everybody can see the chat, but I can put the website in the chat if that works.
That would be great. And Becca, you should be able to send it to everyone.
That really is a wonderful, wonderful website to look at because it looks at how is your sleep? How is your eating? How is your activity level? How are your social supports? All of that impacts your pain experience.
So the next question, are there any joint supplements that should be avoided by someone with a bleeding disorder?
I'm going to say yes. But off the top of my head, so like arnica is one that I get asked about a lot, which is like an herbal pain medication. It can be used topically, but I think you can also take it as a tablet. Turmeric is another one. And, with a lot of those types of things, if you're getting it in your diet, well, not arnica, but turmeric, that should be safe. But taking actual supplements that can cause an increase in bleeding. So there's a couple of guidelines depending on what it is. I know that we've at times suggested that you could try it, but just be really aware of, like, are you having more bruising? Are you having more bleeding? If so, then maybe it's probably not a good idea to take that. And then I believe that it is, I believe it's on the National Hemophilia Federation website. They have a resource for over-the-counter herbal supplements and things that can increase bleeding. So there is kind of a list of things that you should avoid. No, that's not like a super concise answer, but hopefully that's helpful.
Thank you, Becca. The next question, how do you get answers or help for joint pain when no one can seem to find an answer? They have suspected arthritis, but will look into no relationship with my VWD.
That's it. I know, I was going to say, don't give up. I mean, I think you keep bringing it to the forefront. And I don't know how you would handle that, Becca, because I guess I feel very fortunate at the center where we talk about pain a lot, and it can change. It may get better and it may get worse. It's like, so it's a topic that I continually investigate, and I continually try to help figure it out. And sometimes it's a referral to another care provider. Sometimes it's imaging. Sometimes it's exercise. I think, like, we're starting to look a little bit more at, we just did a study on mindfulness meditation and gentle yoga movement, combining those things for pain. And the feedback on that class was really positive. It's like they felt that they had more tools in their toolbox to deal with it. It's not that their arthritis got suddenly better, or they had tons of more joint range of motion, but they just had more tools to calm down their system or the pain in those moments. So I think that's a good question. I think it's like, you just keep asking, and we just, at a center, I know we want to keep addressing it and working with you.
Yeah, and I think I would say the same thing, and just emphasize that, you know, I think the reality is sometimes you just have to be your own best advocate, and it sounds like you've tried. And sometimes just being persistent might be enough to get somebody to think about it a little differently, or, you know, seeing if there is somebody else that you might be able to loop in. Do you need a referral to rheumatology? I don't know, maybe not, but do you need to, you know, have somebody checked for hypermobility, other things that could be causing it, if they seem to think that it's not related to your bleeding disorder. And then, you know, I don't like to advocate that you like find somebody else to take care of you, but sometimes if you feel like you are not getting the answers that you need, it's okay to like seek a second opinion. And, you know, depending on where you live, there might be somebody else that you can do kind of a consultation with and see if you get any different recommendations from.
And I think also maybe outlining your goals. It may be, it's not that you want decreased pain, you want to spend time with your kids, you want to be able to get through an 8-hour day and exercise at a gym. So sometimes addressing the goals can be effective. And that will be, it's a starting place to develop a plan for what's going to work. And oftentimes, again, I'll say that people will say their pain hasn't changed, but they're able to do more and they feel better about that. And that's kind of a little bit of a mind flip in talking about not pain as the symptom, but the function that you want to achieve.
Thank you both. We still actually have a ton of questions, which is great. So I want to say to everyone, keep in mind that we keep these questions and we will answer them at some point. We will often use the questions to inform additional webinars or content for our symposium. So we apologize that we can't get to everything. I'm going to end with one that has been asked. A few people did comment on, you know, women in particular, are they seen as hypochondriacs? Is their pain not taken seriously? So that might be something you guys could address a little bit. But then also, if movement is best for pain, how do you start when you're in pain? So how do you...
Yeah. I love that question. I love that question because oftentimes I think we think that we have to go for a 10-mile walk or we have to do something big. I put the therapy up there because sometimes even just moving a muscle without moving a joint can be really helpful. So putty is like one of my favorite things ever because you start to tap into other sensations, deep pressure, light touch, warmth. Some of those sensory inputs can help decrease an amped up pain system. So I can take my hands for a walk if my ankle hurts. And believe it or not, I can move and do an exercise that's away from the joint that's painful. And that can have a huge impact. If I settle my nervous system down a notch or two, then I'm going to be able to move that ankle. But maybe I start at the knee or the hip or the hands before I go to the ankle. So we often get very tunneled vision on it. This is what hurts and this is what I have to strengthen. But oftentimes, because that is pain, there's a lot of other things that have gotten weakened that we can start with first.
Excellent.
And Nancy, you would be able to speak to this more than I would, but I know I've heard you talk about like isometric exercises where do you want to?
Yeah, so isometric means you're moving a muscle, but not moving the joint. So just for a visual, it's like I can have if I need to like straighten out my elbow, if I give resistance to that elbow, and so I'm not letting it go straight, I'm moving the muscle without moving the joint. So oftentimes that can be a great place to start. So there's lots of ways to do an isometric exercise. And maybe that can be a whole talk in itself. Like, how do I use a muscle without moving the joint? And that can start that process of strengthening. Because if there's a muscle, we can strengthen it. If you don't have a lot of movement, we can still strengthen it. So it's just getting it down to a level that you can start to feel the muscle activate and it's not increasing the pain.
Thank you.
Yeah, and in regards to women being labeled as hypochondriacs and not being listened to, that's a hard one. I think that, there's probably some history there in terms of, it wasn't until fairly recently that, women with low factor levels were considered to have hemophilia as opposed to just being carriers. And so this idea that, women can't bleed might inform some people's opinions as to whether women could have joint pains that might be related to bleeding. So I think I would say in general, there's not, an overarching medical idea that women don't have pain and are hypochondriacs. But I think maybe within the bleeding disorder community, it might have been a little bit like kind of pushed to the side. Well, this isn't a joint bleed, so it's not related. And it may be that it's not, but it does kind of go back to that, what we were talking about before, and learning to kind of keep asking the questions and finding someone. I know I've talked about this before in other talks that I've done about, if you're at a center where you have more than just your doctor, if you're lucky enough to be at a hemophilia treatment center where you've got a whole team that's taking care of you, even finding just one person that you can like have a rapport with and be able to talk to about it. And then maybe they can help advocate for you and help figure out, who you should go to next, what the right way is to approach your concerns that seem like they're not being met. I don't think that you should ever feel like you can't bring things up to your providers. I know that that's a common thing, and maybe that's from previous experience, but I'm a big advocate for, speaking up for what you need and asking for it and pushing for it. Knowing that there may not be a great answer, but but until you ask, you know, that's kind of where you can start that process. Hopefully that helps.
Thank you. Two great answers. And we are out of time. We've actually gone over. Thank you to Nancy and Becca for willing to stay on a bit over to answer more questions. We are thrilled that you joined us this evening. This will be available on YouTube, and we'll let everyone know when it goes up so that you can reference it and continue to gain more knowledge. I find that I always learn something new when I rewatch a webinar, so I always appreciate having that to refer to. So thank you everyone for joining us this week. I have got to tell you, we have a phenomenal webinar coming up, and I'm going to put it in the chat in October. For those of you who are familiar with Rob Cooper, he is a Canadian writer, producer, and he is most famous for his work on Stargate, if you know that TV series, because he wrote and produced it, but he also produced a series on HIV and specifically the hemophilia community called Unspeakable. It was phenomenal. So we have a webinar next month that is part 1 in a series. It is called AIDS Awareness Unspeakable. Let's talk about it. And I'm going to grab that link. I thought I had that registration link right up. Hold on one second. I'm going to grab that link for everyone and get it into the chat, because I want you all to be able to reference it. It is going to be something that you definitely do not want to miss. It will be fabulous. So I'm going to drop that link in the chat for everyone so that you can register for the next webinar. The next webinar will take place on October 25th. It's at 7 p.m. Eastern, 4 p.m. Pacific. And it's going to be amazing. We have a lot of people, not just involved in the show Unspeakable, which really, it just brings to light the reality of the Canadian blood crisis, which very much mirrors the US blood crisis and everything that we went through as well. So I think that many of you will find it very interesting. And it's a reminder, HFA's roots is all about protecting patient safety. And we as an organization never want to have anything like that happen again. And to be able to honor and acknowledge our past is part of what helps keep us protected in the future. So please take a look at that. I think it's going to be amazing, and just some real top-notch people in the entertainment industry who are giving their time to join us. So on that note, we are going to end tonight's webinar, and I want to thank you all for attending. Thank you again, Nancy and Becca. We really appreciate all the information you shared and the time you took for Q&A. Everyone have a great evening.
Thank you.